Hello and welcome to Chagpar MD. I'm Dr. Anise Chagpar, and today I have a very special guest with me. This is Dr. Jill Lacy. Dr. Lacy is a professor of medicine and medical oncology here at Yale Cancer Center. Now, many of you may have heard a lot about pancreatic cancer, not only because of Alex Trebek's recent diagnosis, but it seems to be getting a lot more common. Think about all of the stars, Steve Jobs, Patrick Swayze, the list goes on and on. And so I thought, who better than to talk to us about pancreatic cancer than the expert herself. So thank you so much for joining me, Dr. Lacy.
And thank you for having me today.
So Jill, is it just my perception, or is the incidence of pancreatic cancer going up?
So it is true that the incidence of pancreatic cancer is going up very slowly, probably somewhere between 0.5 and 1% per year over the last 10 to 20 years. We don't really fully understand the reasons for that. There are a lot of hypotheses. Some of it may be better diagnostic tools, and we are just picking up more pancreas cancer than previously. But the incidence does appear to be slowly increasing.
And who's at risk? I mean, it seems like, you watch the news and it seems like all the stars are getting pancreatic cancer. Is there something, that predisposes certain people to getting pancreatic cancer? Is that just luck of the draw?
Yeah, so that's a great question. So in contrast to some of the common cancers, such as lung cancer, where we know smoking is just such a powerful risk factor, in pancreas cancer, there really aren't striking risk factors such as tobacco. There are modest risk factors that can increase one's risk of developing pancreatic cancer. Actually, the biggest risk factor, as is true for many cancers, is simply aging. The risk of developing pancreatic cancer under the age of 50 is extraordinarily low, although we do see younger patients even in their 30s. But the risk starts to tick up at age 50 and then really starts to tick up after age 60. The typical age for someone diagnosed with pancreatic cancer is around 70, and it really is, I often call it a geriatric disease or a disease of the elderly, because the majority of our patients actually are older folks. In terms of some of those risk factors, tobacco is a modest risk factor. Obesity or a high BMI is a modest risk factor, and along with that, type 2 diabetes, which goes with obesity, is a modest risk factor. Recurrent chronic pancreatitis of any etiology, whether it's gallstone pancreatitis or alcoholic pancreatitis, is a risk factor. So those are some of the risk factors. And of course, in this day and age, we always think about hereditary risk factors. And about 20% of patients, there's a history that suggests there could be a hereditary component. And anywhere from, depending on the study, 3 to maybe upwards of 10% of patients, if you do genetic testing, you will find a mutation in a gene that the patient was born with, a so-called germline mutation that has predisposed them to pancreas cancer. And the most common gene that we find is quite familiar to many, and that's the BRCA gene, both BRCA1 and BRCA2. And the incidence of that is probably about 3 to 7%, depending on the population that you're looking at. And interestingly, just in the last year and a half or so, the recommendation has emerged from our professional societies that any and all patients with the diagnosis of pancreatic cancer should be referred for genetic testing, because the family history is not particularly sensitive or specific in telling us where it's genetic. So that's a new recommendation, and we do make that recommendation to all of our patients now.
Yeah, because I mean, you think about those 3 stars that I talked about, Alex Trebek, Patrick Swayze, Steve Jobs, all of them, none of them were obese, none of them were terribly old. We don't know about their diabetic status, but, it just seems like sometimes these conditions affect people out of the blue almost. And yet it seems to be pretty lethal. Can you talk a little bit about how it presents and what the prognosis is?
Sure. So you use the word lethal, and we talk about pancreatic cancer being the most lethal common cancer. It's actually not a common cancer relative to some others. There are close to now 60,000 cases a year. And you contrast that with breast cancer, over 250,000, lung cancer, same thing, over 200,000. But it's highly lethal. So there are close to 50,000 deaths. So the mortality approaches the case rate. And it does have the highest mortality of the common cancers. I do have to say, though, that we actually have seen a slow but steady improvement in overall survival. So back when I started my training some many years ago, the 5-year survival was in the range of 2, 3, 4%. And it has just slowly ticked up, and it's accelerated over the last probably 15 years and is now approaching 10%. So that's a gain. It's not anywhere where we need it to be, but we are making slow, incremental progress. We haven't had a major breakthrough, but we're making slow, incremental progress.
And so is that, I mean, do we have, for many of the common cancers that we do better in, there's screening. Is there screening for pancreatic cancer? And if not, what are the symptoms, the signs that people should kind of be looking out for as potential ahas to go and see their doctor about with regards to pancreatic cancer? Or is this something that's silent? We did a video with Elena Ratner not so long ago on ovarian cancer and talking about the cancer that whispers. Is pancreatic cancer like that, or are there things that we should be looking for?
Yes, so we'll first start with screening. So again, in contrast to our common cancers, lung, breast, colorectal, cervical, prostate, where we are doing screening, and it's been very effective in reducing mortality, there is no screening recommendation for the average patient. Now, and there's no easy screening for pancreas cancer. That's part of the challenge. To screen for pancreas cancer, at the present time, we don't have a blood test. We don't have a PSA equivalent. It does require a more invasive approach with endoscopy and an endoscopic ultrasound of the pancreas. Imaging with a CAT scan, such as we do with lung cancer, is actually not that sensitive for picking up early pancreas cancer. MRIs are a little bit better, but very costly. So there's no screening for the average patient. If you are deemed to be high risk, so for example, if your mom had BRCA2 and had pancreas cancer, you could enter into a screening program. Those are still considered research, but many of the major cancer centers will offer that, including Smilo Cancer Center. So there's a lot of interest in developing a blood test to screen for pancreas cancer, and I think we're on our way with regards to that, but nothing is approved and available yet. We do hope that screening will improve the mortality. Screening doesn't always improve mortality, so that would still remain to be determined once we actually have a screening test that can pick up pancreas cancer at an earlier stage. So you sort of alluded to the challenges with this disease, and one of the reasons why it is so lethal, and that is that it is silent as it develops and progresses in the majority of patients. So there's really two major ways that our patients present. So most commonly they present with sort of vague kind of digestive issues or abdominal discomfort, some pain, losing appetite, bloating, gassiness, change in bowel habits, back pain. That will generally lead to some kind of an imaging modality, an ultrasound or a CT scan, and the diagnosis is made. The other group of patients, about 30 to 40%, will present with what we call obstructive jaundice or biliary obstruction. So their bile duct gets blocked by the tumor in the head of the pancreas, and that leads to buildup of bilirubin and the yellowing of the skin or jaundice, darkening of the urine, and light-colored stools. Those patients are more likely to present early. So they may have no pain, loss of appetite, weight loss, and just simply may present with jaundice. And those are the ones that actually are more likely to be diagnosed early and potentially curable. So those are the two major ways in which patients do present with pancreatic cancer. So, the challenge is that by the time most patients present with those symptoms, the disease is already advanced, either locally growing around blood vessels, which precludes surgery, or metastatic spread to distant sites, which precludes a curative approach.
And so you and I had talked before the show about a friend of mine who presented in that way. And so can you talk a little bit about, the approach that you take for people who present with locally advanced or metastatic pancreatic cancer that is the majority of patients, and what approaches are there, and how good are the therapies right now?
Okay, so as you just stated so correctly, the majority of patients, 80%, present with disease that is too advanced a diagnosis for surgical resection. And we do know that surgery to remove the tumor, for those that are candidates for that, is an essential part of the curative approach. If you can't have surgery, you may do well for some time, but right now we cannot say that we have a cure. So for those that are operable, the optimum therapy now is an operation and 6 months of a chemotherapy regimen that we've been using for the last 2 years that actually has been an advance in the field for those patients. So we're getting up to a cure rate probably now approaching 50% in those patients with operable disease. So that's an improvement just over the last few years. So we're excited about that. For patients who present that 80% with advanced disease, we really put them in two groups. So one group are those who have metastases, and we determine that from typically just a CAT scan of the chest, abdomen, and pelvis. For those patients, we certainly don't have a cure right now, but we can improve their quality of life often and alleviate their symptoms and significantly extend their lifespan with the treatments that we do have, which are traditional cytotoxic chemotherapeutic agents. And again, there has been an advance in the last decade in regards to chemotherapy for the metastatic patients. Our regimens are more active, and they're better at alleviating symptoms, and they are better at prolonging life. So that's one of the incremental steps that we've made that I alluded to earlier. And then there's this other subset of patients, about 30 to 40% of patients who don't have any evidence of metastases on CAT scan, so that's the good news, but they're inoperable. And why would that be? And that is because the tumor has grown locally, kind of in the neighborhood, and has started to wrap around key blood vessels that are in the neighborhood. And it makes it impossible for the surgeon to get all of the disease out. And that subset of patients, there's also been incremental progress. And again, it relates to better chemotherapy regimens that are much more effective than we had previously in shrinking the tumor and pulling it off those blood vessels, often used in combination with radiation, that then allows the patient to ultimately undergo a successful operation. So for those patients now, if you look at some of the studies that are out there, 20 to up to, in some studies, higher than 50% of patients are ultimately able to go on and get an operation. And some of those patients are long-term survivors and presumably cured. So that's also incremental progress for that subset of patients.
So for the patients who are either resected for cure or the patients who have metastatic disease, is there a way for us in a non-invasive kind of way to follow these patients to see whether they are recurring? So whether that's a blood test or imaging, like what is the surveillance of these patients?
So after patients have a curative treatment, which would be the operation and the 6 months of that, I call it a cocktail, a 3-drug chemotherapy regimen called FOLFIRINOX, we do follow these patients regularly with CAT scans. We do a blood test that sometimes is a harbinger of recurrence. That's called a CA19-9. because we do see that if we detect the recurrence at a time when patients are still physically well and without symptoms, we have, I think, better results with treatment and a greater opportunity to offer patients exciting investigational therapies if they're still healthy and well. So that's how we follow patients. People are looking at other more sensitive tests such as circulating tumor DNA, but that's not yet ready for prime time.
You know, oftentimes we talk about immunotherapy as one of the new kind of hot topics in oncology, and targeted therapy, where we're using drugs that are really targeted at particular genes that are amplified in a tumor. Have we made any progress in terms of those kinds of personalized therapies or immunotherapies in patients with pancreatic cancer?
So a great question. I would say that pancreatic cancer has frustrated us in terms of the incorporation of a precision medicine approach with targeted therapies or immunotherapy. And there are a lot of reasons for that. We do know that the tumor environment or microenvironment, you know, the sort of the surrounding tissues and cells that pancreatic cancer grows in, which it actually creates. So the tumor creates the tumor microenvironment that is quite, what we say, hostile to the current generation of immunotherapeutics that we hear so much about and advertised on TV, such as Keytruda and Opdivo. So that generation of immunotherapeutics, so those drugs simply don't work in pancreatic cancer, but that does not mean that we've given up by any stretch of the imagination, and we're actively looking at immunotherapy combinations along with chemotherapy. And we and other major cancer centers have clinical trials looking at novel immunotherapeutics, trying to overcome the resistance to immunotherapy that we know exists with pancreatic cancer. And similarly with the targeted drugs, you know, such as are used quite widely in lung and now in breast cancer, you know, we haven't identified a target that is so critically important that and it really drives the cancer exclusively, so that if you target that target, you get a good result. We just haven't reached that point yet. So a lot is happening on the research end, and I think after I would say many decades of negative studies that were sort of empiric in their design, let's try drug X or drug Y or drug A, B, or C and see if they work. It's sort of been back to the drawing board and to try to really understand the biology of this disease. What are the drivers? You know, what about the tumor microenvironment? How can we alter that so these tumors will respond to immunotherapy? So it's been a slow slog because that science takes a long time, but we're definitely making progress, and there's some, I think, very interesting drugs in studies right now that we're hopeful will lead to an advance.
Yeah. So, I mean, I think that the idea of clinical trials is so important because it really does lead to those discoveries and improvements in cure. But I think that because the disease is so frustrating and so lethal, and the progress has been evident but slow, some people, I mean, we've seen this with Steve Jobs and Patrick Swayze, for example, will try alternative therapies. So for the patients and their families out there who may be watching this, what do you say to patients who say, listen, if you don't have anything for me, you know, I'm going to go try whatever alternative therapy might be marketed, snake oil X or, you know, cleanse Y or whatever?
So it's true that it's very common for patients to come to us with literature about alternative therapies. And we do know that a substantial portion of patients, probably more than 50%, are doing some type of alternative therapy, often in combination with standard therapy. You know, I think it's really important to listen to them and actually to see what they bring. And actually, I've learned a lot. And we don't have all the answers about alternative therapy. So what I tell patients is, first and foremost, we have to ensure that it's safe and will do no harm. And if we can establish that, I'm supportive of patients pursuing alternative therapies. There's just so much that we don't know. And for some of the alternative therapies, there is scientific rationale that would potentially support their use. We have to be careful because some alternative therapies can be dangerous if they haven't been well studied. I often encourage patients to work with trained naturopathic physicians who live in this world and are much more in touch with the data than a traditional oncologist, and that often can be very helpful for patients.
Yeah, we did a video with Gary Soffer, who I will link that here for anybody who's interested, who is a naturopathic physician here at Yale. And I think the concept of doing both, you don't have to give up standard of care necessarily to do some of these alternative things, except potentially where there are clinical trials where they may have some restrictions, but really talk to your oncologist. And there are clinical trials that people really should look into, because I think that really does offer not only hope for them, but hope for the next generation of pancreatic cancer patients. So Jill, thank you so much for being my guest here today on CHAGPAR MD. To all of you, I will leave you Jill's contact information, her bio, in the description box below. I hope that you will like, share, and subscribe. Please do let us know what other information we can bring you so that you can enjoy your healthiest life. Until next week, this is Dr. Anise CHAGPAR wishing you all a safe and healthy week.